Now, one of the very important things with the immune checkpoints is their toxicity profile. So in general, these drugs, the benefit is that they don't cause neutropenia, they don't cause thrombocytopenia, we don't get GI toxicity, hair loss. So in general, they can be combined with other agents, which is what we're looking to in the future with monoclonal antibodies, with maybe chemotherapies, with venetoclax, others. However, they have unique toxicities which are immune-mediated, which have been well described by solid tumor. And these are usually organ-specific, so they can be in the form of pneumonitis, which is actually the one we see most commonly, where a patient who's on the immune checkpoint, it can be anywhere from 5 days after starting to 3 months after getting the last dose, comes in with shortness of breath, fever, hypoxia, and sometimes it is in the form of nephritis involving the kidney, sometimes colitis. And so it has taken us about 1.5 years, 2 years to kind of learn of these patterns, because this is not something that the typical AML physician is used to seeing. And also the management is also very different from what we usually do in AML. So unlike in a typical neutropenic AML patient on azacitidine-based combination or chemo, when he comes in with fever, hypoxia, shortness of breath, our knee-jerk is this is neutropenic fever pneumonia, you treat them with antibiotics, you don't want to give them steroids. Here, it's almost the other way around. So we've actually published on this, and we've collaborated a lot with our solid tumor colleagues in melanoma, lung cancer. They said you really have to treat both, because if you do not treat the immune toxicity, it could actually become very severe and fatal within 48 to 72 hours. So it's been a learning curve, and I think as larger studies have begun, it's going to be very important to identify, have knowledge of, and treat these toxicities while we treat the typical bread and butter infection in these patients. The good thing has been the mortality has been very low. We've had only 2 out of 100 patients who have had a death that may have been related to potential underlying immune toxicity. So these are not like the CAR T cells, they're not bispecific, that level, but they do have immune toxicities that one has to be aware of.